Good morning, everyone. I shall be talking on familial unilateral right-sided Brown syndrome in two sisters, a rare report from Indian population. In brief, Brown syndrome or superior oblique sheath syndrome, the eyes are tethered down by the tight superior oblique muscle. Most of the cases which have been reported are either sporadic or non-familial. Autosomal recessive and autosomal dominant inheritance with reduced penetrance are seen. The congenital familial Brown syndrome has a rare incidence of 1 in 20,000 live births. So, first case, a 12-year-old female patient presented to our OPD with the complaints of outward deviation and the diminution of vision in the right eye, as informed by her mother. There was a similar complaints in the elder sibling. The best corrected visual acuity was 6/12 in the right eye and the 6/6 in the left eye. On examination, we could see there was in primary gaze there was 30-degree exotropia in the right eye and the left eye was hypertropic. On elevation we could see the limitation of -2, and on the levo elevation we could see the limitation of -4, and on the dextro elevation we could see the limitation of -2. So there was more limitation in levo elevation. And on doing the prism bar cover test, we could find the 45 prism diopter horizontal deviation and 20 PD vertical deviation. And on the fundus photography, we could see the intorsion in the right eye. Second case, a 15-year-old patient, which was the sibling of the first patient, presented with the similar complaints like outward deviation and the diminution of vision in the right eye. There was similar complaints in the younger sibling. We could find out there was right-sided head tilt in this patient. The best corrected visual acuity was 6/6 in the both eyes, and on extraocular movements, we could find the 15-degree exotropia in the right eye, and the left eye was hypertropic. And on similar findings was seen. There was -4 limitation in the levo elevation, then -2 in the elevation, and in -1 in the dextro elevation. And on prism bar cover test, we could find the 30 PD vertical deviation and the 20 PD horizontal deviation. And on fundus photography, we could find the paradoxical intorsion in the left eye. So, after doing the exaggerated guidance tendon traction test, which was strongly positive for superior oblique in the right eye, we made the diagnosis of familial Brown syndrome in both the sisters. So, we performed in both the patients right eye 8 mm chicken sutures using double armed 50 polyester with bilateral LR recession, which was done 10 mm in the first sibling and the 8 mm in the elder sibling. Intraoperatively, after giving the traction, there was conjunctival recession was done in the superior temporal quadrant. We could locate the superior rectus muscle. Then we hooked the superior oblique muscle and we passed our first suture. And after passing the first suture, we took the mark of 4 mm and we passed the second suture. So a loop of 4 mm was created in between, and hence finally the 8 mm loop was created. Outcome: both the patients were orthophoric in the immediate postoperative period. There was the limitation of elevation and adduction improved in the right eye. The alignment was maintained till 3 months of follow-up. So, multiple surgical procedures for the treatment of the Brown syndrome, which includes the sheathectomy, as explained by Brown, tenotomy, superior oblique tenectomy, right silicone expander, suture tendon lengthening, Z tenotomy, split tendon lengthening procedure, and the chicken suture lengthening, which was given by Knapp in 1975. So, favorable post-surgical outcome was achieved in both the patients with chicken suture. So, to the best of our knowledge, this is the first report of familial Brown syndrome from India. Thank you.
That is a good presentation. In your presentation, you said post-operatively you could reach orthophoria. Are you sure you could reach orthophoria just by surgery?
Yes, ma'am.
Or is it orthotropia?
Yes, ma'am. It was the patient were orthophoric, ma'am.
Did you check the sensory elements, stereopsis and all, fusion and all?
Ma'am, the stereopsis was good in both the patients preoperatively as well. In the patient which had the AHP, she had the 60 seconds of stereopsis, stereocircles, and the younger sibling who had amblyopia in the right eye, she was having 4 seconds of
See,
stereopsis.
the second child, you said there was a primary position exo
Yes,
plus a
ma'am.
depression. Then it's not easy to believe that the patient had orthophoria. Okay, go ahead.
Can you describe how the guidance traction test is done?
Ma'am, this is different for the right eye and the left eye. Like if we are performing in the right eye, we have to hold at the limbus at the 10 o'clock and at the 4 o'clock position. Then we have to push the right eye towards the superior medial direction, and then we feel the resistance. And if it is tight, so we have a difficulty and we feel there is resistance. So that was strongly positive in both the patients in the right eye.
Actually, you have to retropulse.
That's
Yes,
the
ma'am.
important thing. You need to retropulse the
This
globe,
yeah.
and you have to actually tort it
Yes.
over the superior lobe.
Yes.
But then also, these are very difficult cases. So to achieve a ortho, it is really very difficult. Whatever these cases are, whatever we do,
Yeah, ma'am.
even after doing chicken sutures, also there will be some limitation of
Yes, ma'am.
elevation in.
Ma'am, we didn't follow the patients after 3 months. Actually, she was both the sister was from very far away, so we had the follow up only till 3 months.
Thank you.
Thank you.
you.